Hello everyone, my name is Graham McCourt from Biomedical. Today we're very fortunate to have Dr. Tobias Becher speaking. He is from the University of Kiel in Germany. He's an expert to have today because of his interest in lung protective ventilation. The topic of adaptive ventilation to provide lung protection based on mechanical power is so important to us. Can I suggest to you, please, that we won't have the chat function going, but if you write any questions down under Q&A at the bottom, and what we will do, we'll go through these at the very end. So Tobias, welcome. It's a great honor to have you with us, and we're all looking forward to hearing your presentation.
Thank you so much, Graham. Good evening, or hello, everyone. I'm very honored to be given the opportunity to talk about adaptive mechanical ventilation in this via webinar. I think the reason I was asked to do this webinar is because Via has developed a new mode of adaptive mechanical ventilation, which we tested in a small pilot study in Kiel a few years ago. So that is going to be one topic of my talk, but obviously not the only one. So this is the outline. This is what I'm going to talk about. First of all, I want to explain a little bit about the rationale behind adaptive mechanical ventilation and why it could be useful for us, or more specifically for our patients in everyday clinical work. Then I want to talk about how it works. How do the most common adaptive mechanical ventilation controllers work? How do they adjust ventilator settings? And then I will also talk about some of the maybe limitations of the previous approaches that have been used, and about the rationale behind AVM2, the new controller that was developed recently. And then I'm going to show some study results of our small pilot study where we compared the traditional adaptive ventilation according to Otis Equation with the new mode. So let's get right into it. Why adaptive mechanical ventilation? This is a ventilator screen showing a traditional mode of mechanical ventilation, a pressure-controlled ventilation, as many of us use it in everyday practice. And when we set up a ventilator during pressure-controlled ventilation, there are quite a few variables that we have to think about, that we have to take care about. In this example here, it's 6, and if you blend in some additional variables, there's even 8 to 10 parameters that we can change or have to change to ventilate the patient. Now I want to focus mostly on the parameters that are important to ensure sufficient alveolar ventilation. In this case, in pressure-controlled ventilation, that's inspiration pressure, that's respiratory rate, and it's inspiratory time. When you use volume-controlled ventilation, it's obviously a tidal volume, respiratory rate. And again, you will have to make some adjustment for inspiratory time and perhaps inspiratory flow. So these are the parameters that ensure adequate minute ventilation. And that is one of the foremost goals of mechanical ventilation. We have always to make sure that the patient has sufficient alveolar minute ventilation. So what it all comes down to is we have to select some combination of tidal volume and respiratory rate that ensures sufficient minute ventilation for our patient. And with traditional mechanical ventilation, that is done manually by adjusting pressure, rate, and perhaps inspiration time. So when we look at this tidal volume and respiratory rate that ensure minute ventilation, the first question that comes up is what tidal volume should we aim for to get our minute ventilation? Obviously, the same minute ventilation can be achieved with higher tidal volumes and lower respiratory rates, or vice versa. And since the year 2000, many people are going to answer that it's obvious we have to use 6 mils per kilo predicted body weight. So this was the main result of the RDS network study in the year 2000, that the overall mortality after 28 days was 39.8% with 12 milliliters per kilo predicted body weight tidal volume, and only 31% with 6 mLs per kilo. So this has since then become more or less common sense that it's obviously better to ventilate the patient with ARDS with 6 mLs per kilo than to ventilate them with 12 mLs per kilo. And there are ventilator protocols readily available for download on the internet that tell you exactly that. How should you choose tidal volume and respiratory rate? Well, first select some ventilator mode and then set the ventilator to achieve an initial tidal volume of 8 mLs per kilo predicted body weight, and then reduce it to achieve the final goal of 6 mLs per kilo. And then adjust tidal volume and respiratory rate to achieve pH and plateau pressure goals. So this is one very common recommendation, but the question is, do we actually do this in routine clinical practice? These are some data from the LungSafe study by a large network where many thousands of patients with ARDS were investigated in routine clinical practice. And one of the questions the study asked was, how are the tidal volumes in milliliters per kilo predicted body weight that are actually selected in patients with ARDS? What you see here is that less than 20% of patients with ARDS in routine clinical practice are ventilated with a tidal volume of less than 6 mLs per kilo predicted body weight. And even if you take the upper limit of what is perhaps acceptable for according to the ARDS network approach, 8 milliliters per kilo predicted body weight, still only 65% of patients were ventilated with a tidal volume of less than 8 mLs per kilo. So the answer to the question whether we do adjust tidal volume according to predicted body weight in routine clinical practice is not really. Obviously, this is not what is done by many clinicians during their everyday work. But should we really do this? Is adjusting tidal volume according to predicted body weight really the best way to do this? In the year 2013, Amato and co-workers have published a study that has at least put this into question. What they did is they did a reanalysis of many ARDS network studies, and they looked at the association in a multivariate analysis between tidal volume and predicted body, divided by predicted body weight and mortality. And they stratified the patients according to their tidal volume in subgroups. And this is a subgroup of patients with a tidal volume of more than 10 mils per kilo predicted body weight. And this is the relative risk of in-hospital mortality for this subgroup here. So this is 1.0. And this is a subgroup of patients with around about 8 mils per kilo predicted body weight tidal volume. The relative risk for mortality was more or less the same. When you do a multivariate analysis adjusted for age, Apache risk and other parameters. This is a subgroup with 6 mLs per kilo, and again, the mortality is the same. So there was not really an association in this multivariate analysis between tidal volume divided by predicted body weight and the relative risk to die in hospital. And what Amato did in their study was they scaled then tidal volume to compliance instead of predicted body weight. So instead of dividing the tidal volume with the predicted body weight, they divided it with the compliance of the respiratory system. So that got 5 other groups. So these groups are now stratified according to the ratio between tidal volume and respiratory system compliance. And this ratio is nothing but the driving pressure. It's the delta pressure. It's the driving pressure that is measured during an inspiratory hold maneuver to get the static respiratory system compliance. When you do this, when you stratify patients from high driving pressure to low driving pressure, then you see that the mortality risk goes down, at least in this analysis. So this was a large data set, but it was only one analysis, and it was the hypothesis that driving pressure would be associated with mortality. And that's what they found. So the association between driving pressure and mortality was much stronger than one between tidal volume divided by predicted body weight and mortality. So this is another way to look at these data. When you have here the driving pressure on the x-axis and the relative risk to die in hospital on the y-axis, you see that the risk to die goes up with higher driving pressure. This was recently confirmed in another analysis. Again, it was a multivariate analysis that looked at different models and looked at different ventilator variables. First, in the simplest model, a single ventilator variables, and they checked whether these variables were associated with a higher risk for mortality. So one standard deviation of increase in respiratory rate led to a relative increase in the risk for in hospital mortality by 1.15. So this was significant. Whereas tidal volume by predicted body weight was not really significantly associated with hospital, but tidal volume divided by respiratory system compliance again. So the driving pressure was the strongest predictor of mortality in this model. So there were only two when looking at the single respiratory variables: respiratory rate, tidal volume, driving pressure, PEEP, and plateau pressure. Only the driving pressure and the respiratory rate were associated with mortality. So that's a problem, because we want to make a trade-off between tidal volume and respiratory rate. But here you can see that the driving pressure is obviously stronger associated with mortality than the respiratory rate. Why is that so? When we look at the driving pressure during volume controlled or pressure controlled ventilation, it's very easy to measure. And this is the way we normally measure respiratory system compliance. So we take the tidal volume and then we divide it with this driving pressure to get compliance. But as I said, we can do it the other way around. We can calculate driving pressure by dividing tidal volume with respiratory system compliance. And the rationale behind this is that respiratory system compliance is positively correlated to the functional size of the patient's lungs. So the larger is the patient lung, in general, they will have a larger respiratory system compliance. A tall adult has a higher respiratory system compliance than a small baby. So a baby lung of an ARDS patient has a low compliance. And if you normalize tidal volume to respiratory system compliance, you actually try to normalize tidal volume to the functional size of the patient's lung. So if you ventilate with the small driving pressure, then a patient with a high compliance and a large lung will get higher tidal volume than a patient with a small compliance and a small lung. So adjusting tidal volume according to respiratory system compliance normalizes the tidal volume to the functional size of the patient's lung. So that's why I think that we conclude from these data that tidal volume should be adjusted according to respiratory system compliance more than according to predicted body weight. But again, is this what we do in clinical practice? I already showed you that we do not really adjust tidal volume according to predicted body weight in many patients. So do we do it according to respiratory system compliance? According to the data from the Lung Safe study, again, not really. This is respiratory system compliance. This was a group of patients with very high compliance here, and they had a tidal volume of around about 8 mils per kilo. And this was a group with a little bit lower compliance. Again, same tidal volume, even lower compliance, same tidal volume, even lower compliance, same tidal volume. So it was not really an association between compliance and tidal volume. So no, the clinicians do not in routine clinical practice adjust tidal volume according to respiratory system compliance, unless compliance is extremely small. Then they will choose smaller tidal volumes, but only then. What about mechanical power? Mechanical power is a subject that has been en vogue for a couple of years, and but it's not really new. It's a very old concept, and it is based on calculation of work per breath, and then multiplying work per breath with the respiratory rate. Work is nothing but the integral of pressure times volume change during a breath. So if we look at this figure from a publication of Van der Stey and Chatburn, work per breath is the area that is enclosed by this red line here. So here you see the airway pressure. Here we see the volume. During volume controlled ventilation, airway pressure goes up first to overcome resistance, then pressure and volume go up at the same time. So this is when work is being generated, and then there's expiration. So the area here is the work. And when you take this area, this volume pressure area, and multiply it with respiratory rate, you get mechanical power. For pressure controlled ventilation, it looks a little bit different, but the principle is the same. You increase pressure, then you increase volume, and the area enclosed by the pressure volume loop is the inspiratory work. And when you take the inspiratory work and multiply it with respiratory rate, you get the power of breathing. The unit for power of breathing is joules per minute. What you can already guess when you look at these figures here is that there are different components of work. There is resistive work, there is tidal or elastic work, and then there is presumably work performed to generate PEEP. So you can actually split this into three components: the static work for PEEP, the tidal work to overcome respiratory system elastance. So this is the work component that's related to driving pressure, and the resistive work to overcome resistance. And in this publication by Costa and co-workers, they assessed the association between total power and mortality, and they found, like many other publications did, that higher total mechanical power is associated with higher in-hospital mortality. But when you look at the components of power, then they saw that the PEEP-related component, the elastic static component, so this part of the loop, or this part here, was not associated with mortality at all. But the tidal part of mechanical power, so the one that is associated or related to driving pressure, that was the one that was had the strongest association with mortality, whereas the resistive part of work, again, did not really have, or the resistive part of power did not really have any association with mortality. So it looks like the association of total power with mortality comes mainly from the fact that the elastic dynamic, the tidal power that is related to driving pressure, when this goes up, then this increases lung injury and this increases mortality. So when you have a high driving pressure and high tidal volume combined with a high respiratory rate, then this will increase mortality according to these data. So is it possible to use mechanical power to find optimal tidal volume and respiratory rate combinations? This is from a very old publication by Otis, Mechanics of Breathing in Man, where they showed that for any given respiratory system compliance and resistance combination, expressed as the respiratory time constant, and a given alveolar ventilation target and a given dead space that you need, it is possible to identify a global minimum of mechanical power. So this is the mechanical power per minute, and this is the respiratory rate. And these are the components. This is the elastic component of power, and this is the resistive laminar and the resistive turbulent component of power. And as you can see, higher is the respiratory rate, up goes the resistive power that you need to overcome resistance. Whereas with very low respiratory rates, you have a very high elastic power that you need to overcome elastance. So you will have a high driving pressure. And when you combine these curves, the elastic power curve and the resistive power curves, then you can see that there's a total power curve, which has a global minimum. So it's possible to identify an optimal respiratory rate, according to the publication by Otis and co-workers from 1950, with respect to total mechanical power. And this is from a newer publication by Laubscher et al., who published the first, to my knowledge, adaptive mechanical ventilation controller. And this is a three-dimensional chart that shows respiratory rate that is selected according to this principle, depending on respiratory system time constant. Resistance times compliance is the so-called time constant, which is proportional to the time needed for complete expiration, and the ratio between alveolar target ventilation and dead space. So when you have a very low time constant, which is a stiff lung, so to speak, then you will get high respiratory rates very quickly. Whereas when you have a high time constant, which is a more compliant lung, maybe with a higher resistance, then you will get lower respiratory rates. So yes, in general, it is possible to find automatically identify the ideal respiratory rate tidal volume combinations according to mechanical power. So why adaptive mechanical ventilation? As we have seen in routine clinical practice, the known lung protective ventilation strategies are often neglected when we adjust the ventilator manually. Moreover, when you have a very high clinical workload, which many of us have, you cannot be present at the ventilator all the time. So when there's a change in compliance, you should normally adjust tidal volume accordingly. When you have a patient whose lung deteriorates, gets a lower compliance, you should decrease tidal volume and increase respiratory rate and vice versa. But these adjustments that should be made when you want to adjust the ventilator settings to the patient's lungs cannot be made all the time in routine clinical practice, but this can be automized. And so it's very easy to identify optimal or more or less optimal combinations between tidal volume and respiratory rate in terms of mechanical power automatically. So how does it really work? Again, this is from the publication by Laubscher and al. From the first, who published the first adaptive mechanical ventilation controller in 1994. And this is the controller chart that was published in the paper. I have redrawn this myself to make it a little bit more legible. And this looks very complicated at the beginning. But in the end, what's important for us as clinicians is when we look at the controller is what is the input? What input do we give the controller? So this is a user input here on the left side. This is the minute ventilation. This is the minute ventilation target that the controller should aim for. And then it's important to understand what's the result. And the result is always some combination of respiratory rate and tidal volume that will result in this minute ventilation that we entered as users. So this is how such a controller works. We enter a minute ventilation and we get a combination of tidal volume and respiratory rate that gives us exactly this minute ventilation. So to go in it a little bit more in detail, when we enter the minute ventilation, the controller automatically calculates optimal respiratory rate and tidal volume combination according to Otis equation. What does it need for this? It needs information on respiratory time constant, RC, resistance compliance product, and it needs information on serial dead space. So it has a very simple patient model. This patient model is based on the flow and CO2 measurements of the ventilator, and it gives us time constant and dead space. And then according to Otis equation, it calculates optimal respiratory rate and tidal volume. And then the respiratory rate that was calculated is the spontaneous respiratory rate the patient generates is subtracted from the respiratory rate that was calculated. And then the controller knows what is the ventilator rate that needs to be added. For example, when the controller calculates optimal respiratory rate of 20, and the patient is already doing 10 breaths spontaneously, then there will be 10 ventilator breaths added. And and this is the rate controller that does it. This is so-called PI controller, so the rate goes up slowly. It doesn't go up in one step to the calculated respiratory rate, but there's a slow increase until the target respiratory rate is met by the combination of ventilator breath and patient breaths. Same applies to tidal volume. Patient may generate already some tidal volume, and this is taken into account, and it's when adjusting the inspiratory pressure so that the tidal volume that results should be close to the calculated optimal tidal volume. So this is basically it. We input minute ventilation targets and we get some combination of respiratory rate and tidal volume that gives us this minute ventilation regardless whether the patient already has some spontaneous breaths or not. And when the patient mechanics change, the time constant changes, then the combination of optimal respiratory rate and tidal volume will be adapted. So I already talked about it, that it's possible to identify this optimum respiratory rate according to Otis equation. This is how it looks like. To be honest, I think most clinicians, as I am a clinician as well, do not really understand the maths behind this. But what we have to understand is that this equation gives some optimal respiratory rate and that it needs to know the respiratory time constant. It needs to know the alveolar ventilation we're aiming for and the patient dead space. And this is pi, so this is just a constant. So these are the parameters that go into this equation, and then it can yield us resulting more or less optimal respiratory rate in terms of mechanical power. However, what we should always be aware of is that this is based on the assumption of a sinusoidal pressure curve during inspiration, as with spontaneous breathing. Otis in 1950 was never concerned with optimizing any ventilator settings. He was concerned with understanding the mechanics of spontaneous breathing. So during unassisted ventilation, this is what the pressure volume loop looks like, more or less. You get a slow increase in muscle pressure, and it has this, the muscle pressure that the patient generates has this more or less sinusoidal shape. So it's not rectangular as with pressure controlled ventilation, nor is the pressure going up like this as with volume controlled ventilation, but it has this very unique shape. And this is the shape that was that is the assumption behind Otis equation. Therefore, this equation may not be perfectly ideal for optimizing pressure controlled ventilation, because the assumption behind it is a little different regarding the pressure, the shape of the pressure curve, than is the case with pressure controlled ventilation. This is what adaptive mechanical ventilation with AVM looks like on a ventilator. So you have to put in the patient height, because this is needed to calculate predicted body weight and to give an estimate of serial dead space. And then you have to enter the minute ventilation, which is normally entered in milliliters per kilo predicted body weight per minute. So 100 means 100 mils per kilo predicted body weight per minute. And this gives you, in this case, in a patient with a predicted body weight of 66 kilos, it's here, it gives you a target ventilation of 6.6 liters per minute. And then the respiratory rate tidal volume combination to achieve this minute ventilation target will be selected automatically. There have been many studies since the first publication of the adaptive lung ventilation controller by Laubscher and colleagues in 1994. And some of these studies have shown that when you do use adaptive mechanical ventilation with adjustment of tidal volume and respiratory rate according to Otis equation, this helps to shorten weaning times in patients with COPD. It can also accelerate extubation and simplify ventilatory management after cardiac surgery. It can reduce weaning times and again simplify respiratory management after a liver transplant, and also in medical ICU patients. It has been shown that this may be helpful in reducing weaning duration and obviously clinical workload. So there are many encouraging data regarding the use of adaptive mechanical ventilation in different patient populations, mainly medical patient populations. However, there has been criticism, obviously, and one criticism that I'm picking out arbitrarily here is this publication by Dongelmans and co-workers published in Anesthesiology in 2011, where they said that adaptive support ventilation may deliver unwanted respiratory rate tidal volume combinations in patients with acute lung injury ventilated according to an open lung concept. So what does this mean? They had some patients that were on pressure controlled ventilation. They had ARDS, as we would say today, according to the Berlin definition. And in the beginning, they were on conventional pressure controlled ventilation with a tidal volume of 6 to 8 mils per kilo. And then they were switched to ASV, to adaptive support ventilation. And in some patients who had a higher respiratory system compliance, they saw, these are the red squares, that the tidal volume went up when switching the patient to ASV. So the tidal volume went from 6 to almost 9 milliliters per kilo predicted body weight. Whereas in patients with lower respiratory system compliance, the tidal volume remained stable at a very low level. And then, well, they performed a recruitment maneuver, which again increased compliance. That's why they talked about an open lung concept, because they performed some recruitment maneuver, and with higher compliance, tidal volume went even more up with adaptive support ventilation. By the time in 2011, it was not so well known that it is maybe a good idea to increase tidal volume in patients with higher respiratory system compliance. But this was seen as very critical. They said this is not lung protective in patients with ARDS to ventilate them with more than 8 mils per kilo predicted body weight. So this was one of the criticisms of ASV, that it may ventilate patients with high compliances with high tidal volumes due to the equation that's behind it. Well, this was certainly not the only reason for developing AVM2, but it was maybe some additional rationale to look whether there was some potential to, even though the adaptive ventilation according to Otis equation is already relatively lung protective, to improve the lung protection even more. As I said, power according to Otis equation is calculated with the assumption of a more or less sinusoidal pressure curve. So this is how the volume change over time, or the flow, looks like during spontaneous breathing. And this is the assumption behind the Otis equation, that there is this more or less sinusoidal flow or pressure during spontaneous unassisted breathing. Whereas pressure-controlled ventilation, or I said, you have more square wave pressure waveform like this, and all adaptive modes that are known to me at least use some form of pressure-controlled ventilation. So you have some more or less rectangular pressure volume waveform, and not a sinusoidal pressure wave as is assumed by Otis equation. So in 2018, van der Staaij and Chatburn published a new equation that is not based on the assumption of unassisted ventilation anymore, but instead of the assumption of a square wave pressure as it occurs during pressure-controlled ventilation. And this is what the equation looks like. Again, the variables that you need to know to calculate the optimal respiratory rate are the same as for Otis equation. You need to know the target minute ventilation, you need to know the dead space, and you need to know the respiratory time constant. And then this equation can be solved with some form of mathematical iteration that can be easily performed in a ventilator. And then it gives you a more or less optimal respiratory rate for the desired minute ventilation for a patient with a given respiratory time constant and a given dead space. Van der Staaij and Chatburn did some simulations, and they presumed that this way of calculating respiratory rate tidal volume combinations would result in lower tidal volumes and lower driving pressure than the traditional method of calculating it according to Otis equation. And so we wanted to test this in clinical reality. That's why we performed a small pilot study comparing adaptive mechanical ventilation according to Otis equation with adaptive mechanical ventilation as it was proposed by van der Staaij and Chatburn. So we did a comparative study between AVM, which uses Otis equation, and AVM2, which uses the new equation. And the hypothesis of the study was that ventilation with AVM2 may lead to more lung protective ventilator settings than the traditional way. So we did a randomized crossover study and ventilated patients with AVM and AVM2 in random order for 1 hour each. And we compared the automatically selected ventilator settings and some respiratory measurements and arterial blood gases between the two modes. We included mechanically ventilated ICU patients who were adults and who gave informed consent. And we excluded patients with a time constant of more than 1.5 seconds because we thought these would be mostly COPD patients, and we didn't want to have COPD patients in this pilot study. And we also excluded severe ARDS with PF ratio less than 100 and and severe acidosis despite manual optimization, as well as severe hemodynamic instability. And unfortunately, by the time we also needed to exclude patients with spontaneous breathing efforts, because by the time we performed the study, AVM2 was not yet optimized for spontaneous breathing. This has been resolved since then, so AVM2 is now able to obviously optimize or to ventilate patients with spontaneous breathing. But by the time we performed the study, AVM2 would simply switch to Otis equation once it recognized any spontaneous patient efforts. And we didn't want that, because then we would have been comparing Otis with Otis, which would not have made a lot of sense. So the primary endpoint of our study was tidal volume, very simply in milliliters per kilo predicted body weight after 1 hour of ventilation with AVM or AVM2. The secondary endpoints were driving pressure, mechanical power of breathing, PF ratio, PCO2, pH. Alveolar minute ventilation was very important to us, because obviously it's easy to increase respiratory rate and decrease tidal volume to get the same global minute ventilation. But the question is, when you take that space into account, will you still have the same alveolar minute ventilation? We also looked at mean airway pressure, because we expected that there would be some changes there, and at very simple hemodynamics. So after including 20 patients, 10 among them with ARDS, with these baseline ventilated parameters, so PF ratio of 250, so they were not severely ill in terms of lung injury, more or less normal capnic, and moderate PEEP levels of around about 9 millibars. And during pressure controlled ventilation, so before we switched them to AVM or AVM2, they had this tidal volume. So we ventilated them clinically again. This is our clinical reality with 8.1 milliliters per kilo predicted body weight on average, and a respiratory rate of 15. So when switching to AVM, on average, patients had a tidal volume of 8.2 mils per kilo predicted body weight, whereas with AVM2, with the new mode, this was reduced by 1 mil per kilo to 7.2 milliliters per kilo predicted body weight. So the expectation was met. AVM2 actually did select smaller tidal volumes than AVM, which did so according to Otis equation. Driving pressure was also reduced by around about 1 centimeter of water from 12.6 to 11.5. So again, this is obviously in accordance with the reduction in tidal volume. And the respiratory rate was slightly higher with AVM2, which was again what we expected. And the total mechanical power, including all components, we didn't do any specific analysis of the single components of power there, was smaller with AVM2, whereas the alveolar minute ventilation stayed exactly the same. Mean airway pressure, interesting enough, was higher with AVM2, significantly higher than with AVM1. So how does that happen? We had a lower driving pressure and lower tidal volume, so actually what we would expect is a lower mean airway pressure. And this is what the developers of AVM2 expected as well, which is why they changed the I to E ratio to counteract this expected decrease in mean airway pressure. While AVM ventilates in general with an I to E ratio of 1 to 1.5, AVM2 will generally ventilate with an I to E ratio of 1 to 1. That's why, despite having lower driving pressure and lower plateau pressure as well, AVM2 still had a little bit higher mean airway pressure because of the longer duration of inspiration that was selected by this mode. I will come back to this in a few minutes. But first, let's look at some other parameters. Respiratory system compliance measured during a static maneuver was higher with AVM than was with AVM2. The decrease was very small, but it was statistically significant. And the same held true for PF ratio. The PF ratio was a little bit higher with AVM than it was with AVM2. So again, we have a small but statistically significant decrease in PO2 FiO2 ratio with this mode that selected lower tidal volume, lower driving pressure, and a little bit higher mean airway pressure. CO2 was exactly the same as as was pH, as were the hemodynamics, no changes in mean arterial pressure or heart rate. So why did we observe a higher PF ratio with AVM that selected higher tidal volume and driving pressure? Of course, I can only speculate on this, so I cannot really tell you for sure, but this is my hypothesis, which I would like to present here. When we have the mechanism of injury that is called alveolar cycling, what happens is when you have a lung that looks like this at the end expiration, we have many alveoli that are collapsed, whereas at end inspiration, some of these get open, and then again during next expiration they will collapse, and then they will reopen, etc. And this, so cyclic opening and closing of alveoli leads to lung injury in the form of so-called atelectrauma. So this is what we call tidal recruitment, cyclic opening and closing of alveoli. This was a very small study which was published in 2011 in Minerva Anesthesiologica, but I think it's very important because what they did is they put patients in a CT scanner, only 9 patients, but still they ventilated them with a tidal volume of 6 mL per kilo and 12. And then when they increased the tidal volume from 6 to 12 mL per kilo, they used, in both conditions, they used CT to measure tidal recruitment quantitatively. And they found that tidal recruitment was lower with 6 mL per kilo than was with 12 mL per kilo. And this is really logical, I think, because the higher, when you have some atelectasis left, higher is the tidal volume, the more atelectasis you will open during inspiration. Sorry. And more will collapse during expiration. So high tidal volume leads to overdistension. This is well known and well understood, but it leads also, and this is less understood, I think, to more tidal recruitment. And the problem is with this is this can improve oxygenation because you open some more lung tissue for ventilation. But it also increases overdistension and atelectrauma, and therefore this may be deleterious for the patient. So it can be when you increase tidal volume for a patient, you get better oxygenation and you think you've done something good for the patient, but in the long term, after a few days or a few weeks, you will have done additional damage to the lung with a higher tidal volume, despite observing this short-term increase in oxygenation. So that's why we think that despite the reduction in PF ratio observed with AVM2, we still think that it was more lung protective than the ventilator settings that were selected by AVM. So to the maybe most interesting question, does AVM and AVM2 adjust tidal volume according to respiratory system compliance? To answer this question, we calculated a correlation between static respiratory system compliance on the x-axis and tidal volume in milliliters on the y-axis. And what we saw for AVM, the traditional mode, according to Otis equation, there was a positive correlation between respiratory system compliance and tidal volume. So when you have a very low compliance, the likelihood is high that you will get a lower tidal volume with AVM according to Otis equation. When you have a high compliance, the likelihood is higher, statistically speaking, that the mode will select higher tidal volumes. And the coefficient of correlation was positive with an R of 0.57, which was also statistically significant. For AVM2, this correlation was much stronger. You see here an almost linear correlation between respiratory system compliance and tidal volume that was selected by the automated by this mode. The coefficient of correlation was 0.86, which is highly significant. So when you are the higher is your respiratory system compliance, the higher is the tidal volume that AVM2 will select according to these results, which means that AVM2 does in fact adjust tidal volume to a parameter that is proportional to the functional size of the patient's lungs. So a patient with a lot of lung tissue available for ventilation will get higher tidal volumes than patients with a baby lung that is very small and has a low compliance. So we interpret this that in a way that mechanical ventilation with AVM2 is actually likely to be more lung protective than with AVM according to Otis equation, because It led to lower tidal volume, driving pressure, and mechanical power. And moreover, the tidal volumes were highly correlated to respiratory system compliance. So patients with more compliant lung receive higher tidal volumes. The lower tidal volumes and plateau pressures led to a slight deterioration of BF ratio and compliance, and this could be explained by less tidal recruitment with AVM2s. This means that the plateau pressure remained below the critical opening pressure of some lung units with AVM2. So despite the higher mean airway pressure that was caused by the longer duration of inspiration, the fact that the airway pressure did not exceed a certain threshold with AVM2 meant that some compartments may have stayed closed in patients with AVM2, whereas these may have been opened with AVM. At least that is the interpretation. So to sum up, adaptive mechanical ventilation modes obviously decrease clinical workload because you do not have to adjust the ventilator as frequently. And they always automatically and continuously adapt the ventilator settings to the changing mechanical properties of the patient's lungs. This facilitates weaning and aids in ensuring continuous lung protective ventilation. And in comparison to traditional adaptive mechanical ventilation, according to Otis Equation, AVM2 leads to even more protective ventilator settings in terms of tidal volume, driving pressure, and mechanical power. So that's it for my talk. Thank you very much for attending, and I'm looking forward to any questions and lively discussion.
Thanks, Tobias. Much appreciated. That was a superb talk. It really was. I think for a lot of us, it reinforced the importance of optimal breath selection and energy from the ventilator. I just have one question to at least to start the discussion off. What's your thoughts or comments on mechanical power and PEEP? For example, if you're increasing the PEEP using AVM2, does it change things because of compliance, or does it make a big difference? Do you know or not?
So when you calculate mechanical power according to Gattinoni, that means you include the PEEP, the pressure component needed for PEEP in the power calculation. Then whenever you increase PEEP, you increase power. So the lowest PEEP will always be the most lung protective according to this way of calculation. This is highly debatable, I think, and I also think that the results by Costa and co-workers that I've shown that analyze the components of mechanical power impressively show that the PEEP related component of power is not so important. So when you increase PEEP, you will increase the PEEP related component of power, but this is not really important. What's important is what happens to the tidal component of power. Let's say the respiratory rate remains the same and the driving pressure remains the same, then it depends on whether the compliance increases or decreases. If compliance increases and you are on pressure controlled ventilation, it could actually be that the power increases because you get more tidal volume with the higher compliance. Whereas when you're on volume controlled ventilation, you increase PEEP, you get a better compliance because you're recruiting the lung. Then the pressure that is needed to generate the tidal volume will go down, as will the tidal power. So the driving pressure related component of power. So when you keep the tidal volume the same, you increase PEEP, you get higher compliance, then you will get lower mechanical power. If you do not keep the tidal volume the same, but if you let the tidal volume increase during pressure controlled ventilation, this could, in the case that the compliance increases, lead to higher mechanical power. When you're doing it manual, when you're doing it automatically with an adaptive mode like AVM or AVM2, this will always, when you achieve a better compliance, this will in general lead to less mechanical power because the automated mode will adjust the pressure to keep the alveolar minute ventilation the same.
Thank you. So we actually have a few questions already. The first question was really on which ventilator does have AVM. So it's actually on the Bella Vista. So we'll just leave that aside because it's a very simple question. Quite an interesting question, which it says, since we have unwanted volume and respiratory rate that will affect the flow directly, which means the IE ratio will dramatically be affected. So how would ASVE be better for a COPD patient? Can you read that? It's the last question. Basically, we're talking about AVM2 for ARDS, but normally it's with COPD patients, you would normally see like a 1:2, 1:3 IE ratio, right?
So what I did not mention in my talk is that AVM and AVM2, they always ensure a sufficient duration of expiration because they measure the respiratory time constant, the product resistance and compliance. And they make sure, and in general, they, roughly speaking, they say that you need at least 3 times this time constant to ensure complete expiration. So regardless whether you use AVM1 or AVM2, it will make sure that the expiration time is sufficient to allow more or less complete emptying of the patient's lungs, which in the case of patients with COPD, with a very high obstruction, may lead to very low respiratory rates and to a very low I/E ratio as well. So, and this is something that is not selected manually always, but it turns out that when we look at the data of the patients with COPDs in the studies, that this appears to be beneficial. It appears to be beneficial to make sure that you, even in patients with COPD, you have more or less enough time for complete expiration, more or less. It's not 100%. It's not like, it's not exact science, but it always tries to adjust expiration time to make sure that you get complete expiration. And this may lead to low respiratory rates and high tidal volumes in patients with COPD and to low I/E ratios.
Do you think going forward that the adaptive modes have major benefits in terms, not just in terms of replacing the manual settings? For example, like you mentioned before, tidal volume is a guesswork. Respiratory rate is a guesswork. Do you think that the adaptive ventilation modes have not been researched correctly to show their true benefit for optimal breathing patterns? For example, comparing, AVM to say PRBC or AVM to volume control for ARDS patients?
Sorry, I didn't fully follow. Sorry.
No, I'm just making the point, Tobias, or asking the question. Do you feel that the adaptive ventilation modes have benefits over the existing modes for optimal breathing patterns?
Well, personally, I believe so. I believe that that adaptive modes are the ones that do actually respect the patient's respiratory mechanics. They look at the time constant and they adjust respiratory rate and tidal volume according to time constant, dead space, and minute ventilation requirements. I think that these are the smartest modes that are available today. Yes. There may be better modes in the future, but today I think these are the smartest modes because they really take into account the patient respiratory mechanics. So this is much better than auto mode or something like that still uses some very, very fixed ventilator settings and do not really look at the lung mechanics of the patient.
So we have an interesting question, which is lowering the minute ventilation will also lower power, right? What ratio of hypercapnia is to the power acceptable? I think that's a very good question.
Yeah, unfortunately, I cannot really answer this because it depends on many things, I think. First of all, I would like to point out that lowering minute ventilation to 85% does not always mean hypercapnia, because I think that this setting of minute ventilation in a percent is very misleading. This is a decision that was made in the 1990s by some engineers with whom I do not really agree. What does percent minute ventilation mean? Percent minute ventilation means milliliters per kilo predicted body weight per minute. So 100 milliliter per kilo predicted body weight per minute is a very arbitrary value. It doesn't mean that it's 100% for every patient. because I may be a little bit obese and then I need more minute ventilation per kilo predicted body weight, or I may have sepsis and then I will need 200 or 250 milliliters per kilo predicted body weight to achieve normal capnia. So there may, on the other end of the spectrum, very well be a patient where you choose 85 mils per kilo predicted body weight and you get perfect normal capnia and no problem at all. So it's not like 100 milliliters per kilo predicted body weight is ideal for every patient. You have to adjust this to achieve the CO2 target. And in one patient to get CO2 of 40, you need 100. In another patient, you need 150. And in the next patient, you will need 80. So this is, when you look this setting, you adjust this to achieve your CO2 goal, and you have to do this individually. So the next step is that this will also be adjusted automatically, which some manufacturers already started to do, but I think this may be the next step, but it's not very easy to do. Anyway, so coming back to the question, which degree of hypercapnia is acceptable? I think this highly depends on the metabolic compensation regarding pH. So in our clinical practice, we look at the pH more than at the pCO2, and we accept generally pH above 7.2. So if pH drops below 7.2, we are going to intervene and increase minute ventilation. But we will first start to get normal capnia. Then when we see that the driving pressure to achieve normal capnia is too high, it's above 15, then we will reduce minute ventilation to get the driving pressure well below 15. And then we see where we end up. So this is the way we do it. We aim for normal capnia in most patients first. And then when we see that normal capnia is not achievable with a reasonable amount of driving pressure, then we reduce the minute ventilation requirements and accept a little bit higher CO2, provided that pH remains above 7.2. This is the way we do it in our clinical practice, but I'm not telling you that 7.2 is the ideal value, because as far as I know, this has not yet been fully investigated.
So we have, I think, three interesting questions. I think the first one I'll read out for everybody is, what disease states are less beneficial for AVM2? So we talk about AVM2 for ARDS or low compliant lungs, but maybe, do you think it has a role for normal lungs?
Yes, I think so. I mean, we included patients with normal lungs in our study, and obviously many of our patients who have still normal lungs are at risk for developing ARDS. So I think we should try to ventilate all patients with, if possible, lung protective ventilator settings. Because I mean, the point of lung protective ventilation is not to cure the lung, but to prevent additional injury. You have always to keep that in mind. We do not really heal the lung by ventilating it, but we have to ventilate the lung in a way that does not cause any additional injury. So even if the patient still has a normal lung, we want to avoid additional injury. I would say that the traditional adaptive ventilation, according to Otis Equation, is fine for normal lungs generally. So it will be very hard to show that less patients get ARDS when you have patients with normal lungs that you ventilate for a day or two, that less patients get ARDS with AVM2 than they get with AVM, because AVM, the traditional adaptive ventilation, is already very good. Or ASV, or whatever mode you want to call it. Many manufacturers are now including these modes because it's not patented anymore. So it's already very good, and I think you would probably have to include tens of thousands of patients to show a real benefit with normal lungs and AVM2 in terms of clinical outcomes. But still, I think the rationale of doing the least harm possible should also be applied to patients with normal lungs.
Another one, how do you see the acceptance of AVM for the ICU staff? Is it easy to use?
Well, adaptive, I can talk about adaptive modes in general, are easier to use than normal modes. And the acceptance is relatively high, even in ICU staff who have been using traditional modes of ventilation for a long time, because they are in general easy to use. The only problem is still, I think that many people, what we just talked about, think that 100% is something like the maximum. That's why I think that the decision to name the target ventilation as % minute ventilation is not very lucky. I think it would be smarter to just give a target minute ventilation in liters per minute and then give a very small number that tells you how much that is normalized to predicted body weight for this patient. So that's the way, if I had developed these modes, I would have done it, because that leads to less confusion. Because many people say, well, my patient is hypercapnic, but I'm already at 100%. So what should I do now? And I tell them to go to 150%, but they don't understand that, because they think 100% is something like the maximum. So I would not call it % minute volume. That's the one change I would do if you want to improve the acceptance even further.
I fully agree. It's been one of my bugbears as well. But we have a very interesting question here on PEEP. And the question is, I have never understood why PEEP was ever included in estimations of power. So PEEP is static and variable power is energy per second. Therefore, PEEP cannot ever contribute to power, because PEEP has no time dimension. Thus, including PEEP in power calculations is nuts and defies simple physics. Please comment.
Well, actually, I wanted to keep PEEP out of our power calculation as well. But, well, for some reason, we needed to keep it inside. Anyway, I think that the work is pressure times volume. That's what work is, just a pressure times volume. So if you want to calculate the work that a ventilator performs against ambient pressure, then it's correct, in my opinion, to include PEEP, because that's the work that the ventilator, when you take the ambient pressure in the room as a reference, that's the work the ventilator creates. Work is only done when there's volume displacement. So the PEEP per se does not lead to any work. That's true as long as you have no volume displacement. But as soon as you add on top of that, you have some pressure value, and this pressure includes the PEEP already. And then you get the volume displacement. When you take the whole pressure there that you have, multiply it with the volume displacement, then you get, mathematically speaking, a higher work when the baseline pressure is already higher. Whether this affects the lungs is a very different question, because the lungs are not surrounded by ambient pressure, they are surrounded by pleural pressure. So the actual correct way to do it would be to measure transpulmonary pressure and then take the transpulmonary pressure volume curve to calculate work and power. So that's the way you actually have to do it. So this, including PEEP, is very arbitrary, I think, because it's a very, very hypothetical way of calculating work, because the lungs are not surrounded by ambient pressure. And as I think this paper by Costa and co-workers was one of the most important papers published last year, because for the first time they showed convincingly that when you include PEEP in power calculation, it does not change anything about mortality, about the association between power of mortality. So high PEEP power, whether it exists or not, does not increase mortality, whereas high tidal power, so high driving pressure multiplied with tidal volume multiplied with respiratory rate, this does increase mortality. So I think the debate can probably be closed by there, that whether it makes sense physically or not to include it, clinically speaking, it does not make a lot of sense to include it, because obviously this PEEP related component of power does not contribute to mortality. Right.
So we have one last question, which is ARD secondary to COVID pneumonia. Does AVM achieve automatically permissive hypercapnia or not? We know the answer is no, as you've just said. And the plateau pressure or the driving pressure, can you elaborate a bit more about maybe AVM on that?
Okay, so the permissive hypercapnia depends on the minute ventilation. And patients with COVID may have high CO2 production, and that means that when you set 100 milliliters per kilo predicted body weight as a start, then frequently you will end up with some form of hypercapnia. But then when you increase the minute ventilation target, then you will get, you can achieve normal capnia. So that's the same as for all kinds of ARDS. COVID patients frequently have a low compliance, have a high compliance at the beginning of their pneumonia. So it can be that AVM will select higher tidal volumes at the beginning, and then when it goes on to more atelectasis formation, maybe bacterial superinfection, ARDS, then the compliance will decrease, and the adaptive mode will automatically select a lower tidal volume and higher respiratory rate. And well, plateau pressure then depends on also the compliance and the driving pressure, and obviously the PEEP that you have set. And PEEP is still not being adjusted automatically by AVM, but it's something that you still have to adjust manually.
So, Tobias, that was wonderful, of course. Thank you for your time. I think lots of great questions there, and I'm sure now everybody knows your names. We've actually increased your fame globally, which is it's good, because I think it's a topic that is, I believe, worthy of a lot more discussion. And again, we appreciate your time and your effort, and I'm sure the audience have got a lot out of this as well. So thank you very much, everybody. Thank you so much.
Thank you.